right, hi, I guess it looks like we'll get started. My name is Jennifer Walsh. I'm a Senior Media Officer with the Institute of Medicine. I want to thank you all for joining us here this afternoon for the release of our new report, Strategies to Improve Cardiac Arrest Survival, A Time to Act. Those of you who are viewing it via the webcast, thank you for joining as well, and you can download a copy of the report right now at www.iom.edu/cardiac arrest survival. Just to let you know, this will be a 1-hour briefing unless we run out of questions beforehand. We will start with some opening remarks to introduce the report and then give an overview of the report's recommendations and findings. We will then open up the floor to questions. Those of you in the room are asked to go to a microphone to ask a question, and those of you watching the webcast can ask a question by typing into the Q&A box under the video player and then hitting the submit button. Due to the limited time of this briefing, we ask that you please submit questions only and to identify yourselves and your organization when you ask a question. And with that, it is my pleasure to introduce Dr. Victor Zhao, President of the Institute of Medicine.
Thank you, Jennifer, and good morning. So thank you all for being here today. I'm Victor Zhao. I'm the president of the IOM. I'm also a cardiologist, so that's why I was particularly excited to be here and to kick off this report release. Needless to say, this report, Strategies to Improve Cardiac Arrest Survival, A Time to Act, is of great interest to me. I know this is an important medical issue, and much can be and has to be done to improve the treatment and outcome of cardiac arrest in the United States. Before I begin, I'd like to thank the committee for their outstanding work. I know this was not an easy task. It was a very complicated issue, and I'm particularly grateful for their work and grateful to the leader, Bob Graham, the chair, but also for the presence of some of the committee members, Diane Atkins over here, and Tom Afterhyde, and also Lance Becker. So thank you very much for being here. We look forward to your comments and your reporting us the findings of this very important study. I also want to thank the staff put in tremendous amount of time and effort into this report. That's Meg McCoy and Kathy Liverman and Ashna Cabria and Brian Woodbury. So, how did this study begin? Well, it began when an idea from our members who were concerned about the stagnant survival rate from cardiac arrest over the past 3 decades. Also, if you look at hospitals and communities, there's big variation in outcome between different communities and the hospitals. So as a cardiologist, I'm certainly familiar with cardiac arrest and how the consequence of inadequate treatment can impact individuals, family members, and friends, and less time than it takes actually for some of us to pour and drink a cup of coffee each morning. That's how important it is. As you're here today, cardiac arrest affects almost 600,000 people in the United States each year, and based on most recent estimates, the survival rates are in the single digits. So in fact, cardiac arrest ranks the 3rd leading cause of death in our country. And yet, I would say that many people in the community and our social circles, our families, don't know that much about cardiac arrest. It's not that they've never heard of it, but they certainly don't know that much and understand it. Cardiac arrest is a catastrophic disturbance of the electrical rhythm of the heart, leading to stoppage of the heart, and that can lead in sudden death. So the question is, why doesn't cardiac arrest resonate with the public the same way as stroke and cancer does? Why aren't the public and policymakers asking more questions about improving the care for cardiac arrest as a nation? As you hear from the committee members, there seems to be a lack of coordination in strategy and messaging between resuscitation community, public health, and clinical research programs, and general policymakers. Now, the inherent complexity of responding cardiac arrest does not make the task easier. Communities and healthcare systems must be able to facilitate the timely treatment and seamless care transitions. Care models has to fit local needs and resources. As you hear, another problem is lack of comprehensive data and reliable measurement tools, so you can really measure and improve, in fact, the outcomes of cardiac arrest. These are not easy questions to answer because they involve complex social, political, and practical considerations and perspectives. This leads me to the work of this committee. So to address this problem, the American College of Cardiology, the American Heart Association, the American Red Cross, the Centers for Disease Control Prevention, the NIH, and U.S. Department of VA asked the IOM to review factors affecting resuscitation research and outcomes in the United States. So we convened a 19-member committee chaired by Dr. Bob Graham, which met 5 times over approximately 18 months. As you hear from Dr. Graham in a few moments, this committee was given a very broad statement of task, which includes questions about data, research, clinical practice, the role of emerging technology, strategies to improve the treatment of cardiac arrest, and patient outcomes. And I really take my hat off to them for really tackling such a big issue. Each topic will be examined in great detail, and it will be in the committee's report. So over the next 30 minutes or so, you'll hear from the 4 committee members, and they walk you through their findings and recommendations, after which they'll take questions from the audience. I'm first to admit that this is an ambitious report, questioning many accepted knowns and asking what conditions are necessary to advance the field and improve the outcomes following cardiac arrest. I also believe that this report has the potential to catalyze the necessary action involving many stakeholders nationally. So in summary, there are complex challenges and barriers to successfully treat cardiac arrest that occur in both community and hospitals. However, if existing and developing capabilities are leveraged and stakeholders are aligned and working effectively together, I believe the system of cardiac arrest response can be strengthened throughout the United States. For that reason, I look forward to the report findings and recommendation, and let me turn, therefore, the podium over to Bob Graham, who will walk you through the report. Thank you. Thank you.
Dr. Zhao, thank you very much for that, excuse me, for that introduction. It is my pleasure to be before the group today and give an outline of the report. I would reiterate Dr. Zhao's comments and my appreciation from the role of the chair for the work that the committee has done over the last couple of years and the really outstanding work that the staff has provided in pulling this report together. Brian, I'm just going to walk through slides very quickly. If you would go to the sponsor slide. Dr. Zhao has already indicated the sponsors that we had for this report. The support and the initiative of these individual organizations is critical to the IOM's ability to bring about reports such as this and provide the support for the inquiry. The statement of task I will spend just a little bit of time on because that really sets the parameters for how an IOM committee goes about a particular study. We must address all elements of the task, and we cannot go beyond the task. So you see before you the critical bullets there. We were to look specifically at CPR, cardiopulmonary resuscitation, and the use of AEDs, external defibrillation devices, the EMS and hospital resuscitation systems of care, and that word systems is very important. You'll hear us come back to it time and time again in our discussions. The national statistics that we have on cardiac arrest and the derivation of where those statistics come from, the status of research into resuscitation for cardiac arrest, and what, in the committee's judgment, were the essential steps to take next to enhance survival of victims of cardiac arrest. There are some major themes of the report that I just want to go through quickly, and Dr. Zhao has already touched on several of these. Cardiac arrest can strike anyone, anytime. The suddenness is one of the challenges that we have in responding appropriately and successfully to cardiac arrest. One item that's not here between 1 and 2 is helping the public understand there's a difference between a heart attack and cardiac arrest. As we did some of our public hearings, it became very clear that in the public's mind, these two things kind of come together and they are totally different. A heart attack is a diminution or limitation of blood supply to the heart. A victim of heart attack can still talk to you, but they tell you they have pain, the chest pain, arm pain. It is a medical emergency, but you have some degree of time to get them to an appropriate point of care. Sudden cardiac arrest, the individual suddenly can no longer communicate. Their heart, for a variety of reasons, has quit beating. It is an absolute emergency and requires response within seconds and minutes. It requires a system of response. That word, again, that we'll come to several times in our recommendation. Speed and the quality of care in the system of response are critical. There is a lot that we do not know about the basic epidemiology of cardiac arrest, how many times it actually occurs in the United States, who are the victims, what are the differences in terms of age, race, socioeconomics. We need this new data and knowledge. And to make a system work well, you need the leadership and accountability that are critically important to keep looking at how the system is functioning and how quality improvement efforts are actually taking effect. I think this slide, in the interest of time, I won't spend a lot of time on because, again, Dr. Zhao has hit the high points. Our best estimate, which is derived from a variety of different sources in the literature, is about 600,000 individuals every year suffer sudden cardiac arrest out of the hospital or in the hospital. There are wide disparities of results, but there are, thankfully and hopefully, some benchmark communities where public response and systems of care lead to markedly better outcomes for victims of cardiac arrest. And the fact that these benchmark communities exist give us some hope that these recommendations, if attended to by national and local authorities, can lead to an improvement in outcomes for cardiac arrest on a nationwide basis. Now, with that, I would like to turn to the 3 committee members who are individual experts in this field, and they will walk you through the specific recommendations and the reasons for them. And the first to lead off with recommendation number 1 and the background is Dr. Lance Becker. Lance?
Well, good morning, everyone, and thank you, Bob. My name is Lance Becker. I'm an emergency physician from the University of Pennsylvania Hospital, and I've been involved in this sort of endeavors to save people's lives for at least 30 years. Our first problem that the report enumerates is a problem with data. We now know that we need data to characterize the true impact of cardiac arrest. And one of the surprising findings is that we do not really have precision data on how many people die from cardiac arrest each year. While we have numbers that we will present, those numbers are estimates. It is essential to be able to measure this problem. We need to measure the impact of our treatments and interventions so that we can really establish evidence-based practices that will save lives in every community. Unfortunately, the currently available databases are excellent starts, but they are not adequate. No national cardiac arrest registry exists that protects every community. To facilitate informed discussions with the public and policy makers, we need better data at a national level. If I may have the next slide. Our recommendation, number 1, is to establish a national cardiac arrest registry. The Center for Disease Control and Prevention, in collaboration with state and local departments, should expand and coordinate cardiac arrest data collection through a publicly reported and available national cardiac arrest registry, including both out-of-hospital and in-hospital data, to help increase federal and state accountability for current system performance and to promote the actions that we know and we need to improve cardiac arrest outcomes. Thank you.
Dr. Aufderheide.
Thank you. I'm Dr. Tom Aufderheide. I'm a professor of emergency medicine at the Medical College of Wisconsin. Cardiac arrest, more than anything, requires a system response. That is a sequence of actions to optimize survival and functional outcome following cardiac arrest. Those actions need to occur within seconds to minutes if there is hope for survival and good outcome. There are many myths about cardiac arrest that the report addresses. One of the most common is that cardiac arrest is a heart attack, and you've already heard that these two are very distinct entities and completely different. The response is also different. Cardiac arrest, then, is an event. It is an event that occurs throughout our community, and it requires a sequence of actions in order to optimize outcome. Accordingly, a wide range of people need to be educated, trained, and prepared to act well. And these include, very importantly, the public of the United States. These are bystanders who are most often at the scene when an individual suddenly collapses and can provide life-saving care that we know can more than double or at least double survival rates from cardiac arrest by implementing chest compressions and publicly available AED defibrillation. So bystanders, family members, then the first responding emergency medical personnel, the advanced life support personnel providing care, and then our hospitals that provide excellent wish to provide excellent post-resuscitation care. All these systems within our community need to be optimized to optimize outcome from cardiac arrest. Could I have the next slide, please? The model for this sequence of actions is the cardiac arrest chain of survival, requiring early recognition and early access to the EMS system, followed by early chest compressions and CPR and early defibrillation. I would point out the importance of the public that can provide these first three critical links in the chain of survival. This is followed by early advanced life support provided by our professional rescuers, and then early post-resuscitative care at the receiving hospitals. Next slide, please. So time to the first compression and time to the first defibrillation have been demonstrated over and over again in the scientific literature as absolutely crucial to increase survival as well as neurological outcome and functional survival. And if we can improve this, it's the best way to improve overall survival in the United States. Unfortunately, a low proportion of the American public have received training in these basic steps to take in an emergency, including CPR and AED use. Further, there's another myth about intervening in a cardiac arrest emergency, and that is the concern of the public that they need to do these actions perfectly. In fact, any CPR and any early defibrillation delivered by the public is better than no care at all. Bystanders and family members are needed and clearly crucial to activate the EMS system and provide initial first steps to optimize outcome. So recommendation 2 addresses this important issue, which is to, in general, foster a culture of action through public awareness and training. State and local departments of health and education and leading organizations in cardiac arrest response and treatment should partner with training organizations, professional organizations, public advocacy groups, community and neighborhood organizations and service providers, and local employers to promote public awareness of the signs, symptoms, and treatment of cardiac arrest. These efforts require public CPR and AED training across the lifespan. This includes schools, workplaces, and community settings, creating a culture of action that prepares and motivates the public to respond immediately on witnessing a cardiac arrest. Specifically, the committee recommends state and local education departments should partner with training organizations and public advocacy groups to promote and facilitate CPR and AED training as a graduation requirement for middle and high school students. Employers should be encouraged to maintain easy-to-locate and clearly marked AEDs, provide CPR and AED training to their employees, and specifically include cardiac arrest in formal emergency response plans. And local health departments should engage with community and neighborhood organizations and service providers to expand the types and the locations of available CPR and AED training to populations over age 65 and caregivers for this population.
Thanks, Tom. Dr. Atkins.
Thank you. I'm Diane Atkins, professor of pediatrics with a specialty in pediatric cardiology at the University of Iowa. And I'm going to discuss the next 3 recommendations that we have. As Tom has pointed out, survival from a cardiac arrest requires a very coordinated system of care. It requires EMS, emergency medical services, in our communities. It requires care at a hospital. It requires care for patients who might have a cardiac arrest within a hospital. And then it requires the post-arrest care. What we found in our study was that there is no solid system of transparency and accountability in caring for patients with cardiac arrest. There are several sites which can be benchmarked for providing high-quality care, and we studied the characteristics of those systems, and from that we have made several recommendations. The first is to our EMS systems, who have the responsibility to respond quickly and provide immediate care. However, throughout the United States, on the whole, EMS can be a bit fractured. There are different training guidelines and expectations. NHTSA, National Highway Safety and Traffic Association, should coordinate with the other federal agencies and representatives from private industry, states, professional organizations, and first responders to develop standardized dispatcher-assisted CPR protocols and national educational standards for use by all public answering points. One of the findings that we found was that when a dispatcher provides instruction to a person when they call 911, that is very similar to a bystander starting immediate CPR. Dispatchers can instruct people how to give CPR so that it's not necessary to wait for EMS. And we would like that to be more standardized and coordinated through the United States. And then a specific curriculum with a standardized definition for high-performance CPR to be used in the basic EMT training and certification. The next aspect, or the next part of care for cardiac arrest, is within the hospital. And at this time, there again is no solid database for cardiac arrest care. There is a voluntary registry. However, only a small minority of hospitals in the United States participate in that. Those that do have seen an improvement in their care. All hospitals have to be accredited, and therefore we're asking the Joint Commission, in collaboration with the Red Cross, the American Heart Association, and other patient advocacy groups, should develop and implement accreditation standards for healthcare facilities, which are specific to cardiac arrest care for both adult and pediatric populations. This would include those patients who come to the hospital after suffering a cardiac arrest, as well as those patients who suffer a cardiac arrest within the hospital. Within that estimate of 600,000 that we are citing as the number of people who suffer a cardiac arrest, approximately 200,000 of those occur to patients in the hospital. They are different patient populations. They have different underlying diseases and risks of cardiac arrest. And the hospital needs to also have the same kind of response system that we expect in our EMS system. And with the developing accreditation standards, that will help those systems. And then the third recommendation follows directly from the previous two, would be to adopt continuous quality improvement programs through EMS, healthcare systems, and hospitals. We need to assign responsibility, authority, and accountability within each organization or agency for specific cardiac arrest measures. We need to implement core technical and non-technical training, simulation, debriefing protocols to ensure that both EMS and hospital personnel can respond competently to both adult and pediatric cardiac arrest, and to actively collaborate and share the data to facilitate national, state, and local benchmarking for quality improvement. What we also found was that there are certain communities and agencies that do participate in ongoing continuous quality improvement, and those specific sites, which are listed in box 6-3, actually have some of the highest survival rates from cardiac arrest, demonstrating that an organized, high-quality system can definitely improve survival from cardiac arrest.
Okay, thank you, Diane. Lance, back to you. And Diane, if you could turn your mic off.
Another vital aspect is the need for new knowledge and new evidence. Ladies and gentlemen, we need new research in the field of cardiac arrest. To minimize death and to really optimize survival, it is more than the need to simply implement the therapies that we now have. So for example, approximately 70% of first documented cardiac arrest rhythms in the out-of-hospital setting do not typically respond to the use of a defibrillator. This is why we need new research to begin to care for the patients for whom our current therapies fail. There are powerful new technologies and opportunities that are on the horizon. They are not far away, but we need an investment in that research infrastructure in this country so that we can realize those gains in the public health. It's important to support translational, basic, clinical research discoveries that can provide new insights into the etiology, pathophysiology, causation, and the evidence-based practice of resuscitation. Our recommendation 6 is the need to accelerate research on the pathophysiology, new treatments, and translation of science for cardiac arrest. In order to identify new effective treatments for cardiac arrest, the National Institutes of Health, the American Heart Association, and the U.S. Department of Veterans Affairs should lead a collaborative effort with other federal agencies and private industry to build the nation's research infrastructure that will support and accelerate innovative research on the causal mechanisms of onset, pathophysiology, treatment, and outcomes of cardiac arrest. The next recommendation is to accelerate research on the evaluation and adoption of cardiac arrest therapies. The National Institutes of Health should lead a collaborative effort with the U.S. Department of Veterans Affairs, the Agency for Healthcare Research and Quality, and the Patient-Centered Outcomes Research Institute to prioritize health services research related to the identification, evaluation, and adoption of best practices. For example, the use of innovative technologies like mobile phones or social media to increase bystander CPR, or the use of automated external defibrillators, and the development of new implementation strategies for cardiac arrest treatment. Tom?
Thanks. Tom, for the last recommendation.
Unified national advocacy for cardiac arrest is absent in the United States. There is a need for renewed leadership, accountability, and stakeholder advocacy for cardiac arrest in this country. We need sustained federal, state, and local leadership to improve outcomes from cardiac arrest across the United States. The public should expect accountability from their leaders through public reporting of cardiac arrest data related to cardiac arrest. That is, what is the cardiac arrest incidence and outcome in my community compared to benchmark communities in the rest of the country and compared to the average benchmarks in the United States. We need to generate appropriate leadership and levels of accountability. The resuscitation, in order to do that, the resuscitation field needs to coordinate an advocacy effort. Recommendation 8 recommends to create a national cardiac arrest collaborative. The American Heart Association and the American Red Cross, with the U.S. Department of Health and Human Services and other federal agencies, national and international resuscitation councils, professional organizations, private industry, and patient advocates should establish a national cardiac arrest collaborative to unify the cardiac arrest field, to identify common goals, and build momentum within the field to ultimately improve survival from cardiac arrest with good neurologic function. This will require genuine collaboration from a wide range of stakeholders to provide a platform for information exchange about key successes or failures in different systems and settings, to convene working groups on short or long-term national research priorities for cardiac resuscitation as well as post-arrest care. Develop action strategies related to health policy, research funding and translation, continuous quality improvement, public awareness, and training. Produce and update toolkits that can be implemented by various stakeholders to optimize delivery of high-quality care. Hold annual collaborative meetings in conjunction with regularly scheduled health professional conferences, and encourage public-private collaborations to support activities that focus on reducing time to defibrillation and time to first chest compression, and develop technologies that will facilitate automated external defibrillator registries for use in public EMS systems and for other stakeholders.
Thanks, Tom. As the last slide before we go to the Q&A portion, I'll not spend a lot of time on because Meg McCoy and her staff very artfully found a way to place on one slide all 8 recommendations. but you'll see that it is conceptually our way to try to articulate you have to start out with comprehensive surveillance and reporting. All of these other elements that we've talked about in terms of engagement, leadership, continuous quality improvement lead to the eventual improvement of patient outcomes from cardiac arrest. So we placed this figure in the report just as a way to have as a one-page, very quick review of what we think all of the critical elements are and how they are related. Now with that, we have about 20 minutes or so, and I can open the floor up for those in the audience who have a question or comment. We also have probably 200 individuals logged on watching this on the web, and they also have the opportunity to ask questions of the panel here. So that is open for anybody that wishes to do it. While the first person's coming to the microphone, let me acknowledge one other member of the committee who is not with us, who made a very significant contribution to our work, and that's Dr. Mickey Eisenberg, who was the vice chair of the committee. Mickey has worked in King County and Seattle, turning it into one of the benchmark communities that we refer to in the report in terms of outcomes and survival of sudden cardiac arrest. And that experience really informed much of our deliberations. So Mickey, if you're watching, we miss you and hope that we have done a good job in your view. So with that, anyone is welcome to come to the microphone, or Jennifer will be monitoring the web to see if there are any questions.
Well, we do have a number of questions from the web. So our first one comes from Greg Robinson, an ECC instructor at Indiana University Health. He wants to know if it is feasible for educational TV stations to provide programming on the simple steps of CPR for adults and children.
Okay. Tom?
That's an excellent question. The report in our chapter on public awareness reviews a wide range of education and training options. There are many. There are formal CPR courses that have been traditional. There are take-home CPR training courses. There have been video-mediated instruction. There are now cellular apps on individual cell phones. There is a CPR instructor over the telephone. There are a wide variety of methods to train the public that have been demonstrated as effective. The media is in some ways relatively untapped for training purposes. They have not embraced that role, that national public role to date, but certainly would not exclude that option as a potential.
Thanks, Tom. Yes, if you would, please identify yourself and the organization you represent, if any.
Yes, I'm David Belkin. I'm on the board of the Sudden Cardiac Arrest Foundation. I've been on the board since 2005, after I survived a sudden cardiac arrest at a hospital after someone applied an AED to me. Sudden Cardiac Arrest Foundation is an advocate for everything you have set up here in terms of educating the public about AEDs, that sudden cardiac arrest is survivable, that there's a difference between sudden cardiac arrest and heart attacks, and that we advocate the wide distribution of AEDs. But I'm not sure whether you can effectuate what my concern is, and that the government is operating sometimes, our government, at cross purposes. If you go into a federal building, you will see an AED in a box that says, to be used by trained professionals only. Now, what you're saying is that AEDs can be used by bystanders who don't necessarily have to be trained, that immediacy is the issue. So I'm not sure that you can do anything about the boxes in the federal buildings. But I just wanted to point that out to you. And how do we get whomever is responsible for those signs changed? Thank you.
Well, as a former federal official, I will at least take the first cut at that and tell you that the federal government can change. And you'll notice in our last recommendation with the request that a very broad-ranging consortium of interested parties be pulled together, the federal government is part of that. So it's not only the federal government's reach, but how they treat their own employees and maintain their own facilities. And I think you raise a very good point. Having been in the system, I've got a pretty good idea why that wording is there. It's a little bit the same on airliners. But we feel that the advances of AEDs right now really make them available to the public to use. Other comments from the panel?
So first of all, I would like to thank you for your public advocacy for cardiac arrest. And as you can tell with our recommendation number 8, I hope you will step up and continue that advocacy both locally and nationally as we move forward to improve outcomes from cardiac arrest. I share your concern, and I think the committee shares your concern in that in the chapter on public awareness, we address specifically that issue. AEDs may be located in a building, but they may not be located in an obvious location, and so that people in the building don't know that an AED exists. Occasionally, these AEDs are in a locked drawer in a room somewhere. The point that you made, that it says only a professional rescuer, when, in fact, the public can apply these AEDs with great success. My response to that would be that that would be a wonderful issue, an important issue for the collaborative to recognize and to begin making progress on.
Thanks, Tom. Yes, go ahead, and then Jennifer will have one more from the web. Please.
I don't want to attempt to mess up
Excuse-
your
if
last
you-
name.
if you
My
could.
name is Carol Stemple. I'm from LifeWork,
Thank you.
and we're distributors for several manufacturers for AEDs. We're also an American Heart Association training center. So our program is for implementation into the corporate and private sector and in non-traditional areas for use of AEDs. I don't want to mess up your last name, so I'll say Tom. My question is related to something you said earlier. Mr. Graham had mentioned that cardiac arrest can happen to anyone. So my question is, you specifically referred to age 65 and above, and I wasn't clear as to what you were referring to. Could you clarify that?
Sure. The committee strongly recommends a coordinated and effective campaign to educate the public in CPR and AED use, and that such an effective campaign would represent a significant impact in public health in this country. This training really needs to occur across the lifespan. And so we had several recommendations within that CPR and AED training approach. CPR in the schools, CPR in the workplace, as well as targeting individuals over 65 as well as their care providers, since cardiac arrest occurs more often in the elderly, but it literally can affect anyone at any age.
Okay.
Okay, thank you.
Along the same lines, then, as far as the training goes, what my experience has been is that there is so much discrepancy between the organizations with how the training is provided. The content of how to perform CPR and that sort of thing is there, but what has happened over time is in the effort of simplifying and these different organizations competing with each other to have dominance in the training arena, they shorten and shorten and shorten, and therefore the public is not getting the information that it does happen to everyone. They do still think that it's old people or heart attack. And so what would the committee, is there any sort of recommendations as far as uniformity or monitoring and tracking of how the training is being delivered?
Lance, it sort of falls in the recommendations you explained.
Yeah, I think the important thing within the report is the need for collaboration among agencies. And what you have highlighted is that we need that in this country, and we don't have a group that is specifically at a high level examining that, and that is precisely why the final recommendation is such a strong recommendation, the need for a national collaborative that would ultimately be responsible for precisely the kinds of issues that you're addressing. Thank you.
Thank you. Yes, sir.
I'm Dr. Martin Weisfeld. I'm a professor of medicine at Johns Hopkins. And as a prelude to my comment, I just want to say that my own research has been reasonably supported by the National Institutes of Health throughout my career, so I'm not personally complaining. But I hope the press will look at figure 6.4 in the report. This is a figure that Dr. Becker and I and another investigator put together, showing that for disorders that we've really made a great deal of progress on, heart attack, stroke, heart failure, there have been enormous numbers of clinical trials and research papers and research studies that have been funded. And that if you compare that to cardiac arrest, it's minuscule, and it's graphed, and you can see it for yourself. How do you must have thought a lot about that issue. Who's accountable for those decisions? How do you decide? Is it really that the victims of cardiac arrest can't complain? That really, whereas heart failure, stroke, and heart failure, the people who have those disorders complain a lot, and they get attention and they get allocation of research funding that really does make a big difference.
Well, thank you for that question. You've highlighted two very important things. I think it is fair to state that this is probably the world's most comprehensive report on cardiac arrest. And if this were the world's most comprehensive report on a disease like cancer or HIV, this room would be overflowing. So the answer, I believe, is it's all of our responsibilities. I'm so thankful that there's a survivor who has spoken up. I know there are others who are on the webcast and others in the room. And I think that to hear that voice is such an important thing in the progression of our fight to save people's lives in this country. What Dr. Weisfeld has highlighted on research is, in my opinion, a national disgrace. For every dollar that is spent on a disease that involves a death, for a disease like cancer, there's approximately 2 pennies spent in this country on this disease for each death. And you'll see that in the data within this report. For other heart disease, for every dollar that's spent on a death, there's somewhere around 4 pennies spent on this disease for each deceased American. And so I think it's really all of our responsibilities at this point. This is a time to act.
Thanks, Lance. Jennifer, you want to try a question from the web?
Yes, we've also received a couple questions regarding if these PowerPoint slides will be available, and we will try to upload them to www.iom.edu/COVID cardiac arrest survival. And as I said earlier, that's where other materials will be placed as well. So our next question comes from Michael Charles from the Better Outcomes Foundation. And he wants to know, why couldn't the CDC and Departments of Public Health track and report the incidence and death rates from sudden cardiac arrest annually like they do for heart disease, cancer, and stroke?
Okay, I think that goes to the heart of one of our recommendations. Diane, you haven't had a chance to speak, although it wasn't the recommendation you explained. I suspect you have an answer.
I think that that is encompassed in recommendation number 1. We have many diseases in this country for which there is mandatory reporting, most commonly infectious diseases. And although that's a very important part of the role of the Center for Disease Control, it's now the Center for Disease Control and Prevention. It's taken on these kinds of large public health problems. And so what we are advocating for is a mandatory reporting system from which the CDC can publish annual incidence and outcome statistics so that that can be followed. That's the basis for starting an improvement program. You have to know exactly where you are before you can make any improvements, so you have to measure where you are. And that is the basis of our first recommendation.
Thanks. If I could maybe link the last two responses. One of the reasons that we believe we need this reporting system is to really understand and document the nature of the problem. If there is not, in our view, enough investment in addressing a particular problem, that may be because the full magnitude of that problem is not fully appreciated. So one of the first steps that you need to take is being able to document what the actual incidence is. And in that, in the background of recommendation number 1, we're talking about tracking not only the incidence of out-of-hospital cardiac arrest as well as in-hospital cardiac arrest. They would have 2 separate codes. Anyone else in the room? Oh, I'm sorry, I missed you. Please go ahead.
It's okay, I'm short. My name's Jenny Gick, and I also am a sudden cardiac arrest survivor. And thank you very, very much for the work that you've done. I appreciate that, and all survivors do. As a result of my survival, education and outreach and training has become my mission in life, particularly because 2 of my children are also predisposed to the same genetic condition that caused my sudden cardiac arrest and took the life of my oldest brother. So research is very important to me. My question is, these recommendations are so on point and so critical. How do we take that next step? We have the recommendations, we have the organizations. How do we create this central organization that takes this to the next level, that makes it the Susan G. Komen of heart disease? How do we make it so that heart disease isn't just all lumped together, so that the public continues to think of heart attacks and cardiac arrest as the same thing? It kind of needs its own life, but who owns it? How do we as individuals and communities push somebody, whether it's the CDC or NIH or whatever, to create this body that moves it forward?
Well, I think we hope that the report is a nidus that allows the advocacy and the professional organizations that have these concerns and have this priority to come together with their constituencies and start going in the directions that we have advocated. The Institute of Medicine is not an implementing organization. Our role is to bring together experts, as we have done here over the last 2 years, to look very carefully and dispassionately at critical problems and to make recommendations to the Congress, the executive, and to the public, which is what we have done. I think your question, my response to your question is, how do we get going, is We've heard from you, we've heard from another advocacy organization, we've heard from researchers in the field that feel that this is very important. Hopefully we have given you a context and a structure that you can take this report and say, look, these are the right ideas, let's get it done.
Thank you.
Jennifer, I see you again.
Yes, we have another question from the web. This is from Dr. Jim Dunford. He is the EMS Medical Director for the City of San Diego. He asks that the majority of sudden cardiac arrests today are reported via cell phone, but communities are largely unable to measure the time from first attempt to access 911 and the moment the call arrives at the correct primary services answering point. Cell phone tower geolocation inconsistencies can route emergency calls to incorrect call centers, adding queuing time and critical time delays. Would you please comment on why the need for EMS systems to measure the time from first attempt to access 911 for sudden cardiac arrest and the first ring at the correct primary services answering point?
Lance? That's not an answer I know, so I'm looking at you guys.
I think that Dr. Dunforth is exactly correct, that there are challenges with respect to the accurate location of cardiac arrests. We, for example, don't have accurate locations on where AEDs are in this country, and we know that there are cardiac arrests that occur within very short distances to AEDs. We're not able to access those AEDs. There are ambulances that are sent to incorrect locations. These are all the kinds of realities. This is why cardiac arrest is such a complex issue that goes beyond one system, that goes beyond one group being responsible, and why I am, if you will, passionate that we as a community must begin to really address how we can do better and better at exactly some of the very nitty-gritty things like Dr. Dunforth is raising. We all now carry cell phones. And so this new world that we live in is one that we should get in front of. And we should begin to utilize those new technologies in bold and creative ways. And there are experiments that are going on to do exactly what has been called out. And part of what this report does is call for the support so that that kind of research and development can occur within this country. And so I agree with the comment, and I believe that the steps that the report enumerates will take us down that path to correct many of those deficiencies.
Okay, thank you very much. We are about 2 minutes until the hour, and so you will have the last question. At that point, the webcast will conclude, but for those of you in the room, if you have additional questions to any of the panelists, depending upon what plane departures are and everything like that, we can be around here for another 10 or 15 minutes. So please go ahead, ma'am.
Thank you. My name is Mary Newman. I'm with the Sudden Cardiac Arrest Foundation, and I would like to congratulate the study group for all your work that you've done. It's really, I think it's a landmark report that's going to help make a big difference. And on behalf of our community of survivors, as well as all the many people who have lost someone to cardiac arrest, I think this is really going to be a turning point. So thank you for your work. I do have a question. It was stated that in 70% of first documented cardiac arrests, they do not typically respond to defibrillation. Is that because of the rhythm, or is that because of the time delay?
Yeah, go ahead. That's a quick answer.
It's a very good question, a very important question. It is due to both. So there is that what that means is that by the time someone gets there and can put a monitor on the patient, they are no longer in a rhythm that can be shocked. And so some of that is due to delay, and some of that is due to the fact that some people have an initial event that is not a shockable initial event. So there's two populations that account for that.
Thank you.
Okay. With that, let me again extend my thanks to the committee members who have taken the time to travel to be with us today to provide the background of the recommendations of the report. While we were doing that last question, Meg McCoy came up, who has been monitoring some of the email, and goes back to the question before that and said some of our sponsors are already making public commitments to follow through with the recommendations of this report. So I think the question was, what can we do to gain momentum? It sounds like there is leadership within the community out there to move in this direction, and just keep working with them. So with that, thank you all for being with us this morning. We hope that you find this report to be a helpful one. This formal part of the briefing is now concluded. The webcast will conclude, and the committee members will be in the room for another 10 minutes or so if you have specific follow-up questions. Thank you all.